Hello friends, welcome to Creative Medicine. In this lecture, we will learn about. So we have peptic ulcer disease. So in the peptic ulcer disease now, the drug of choice for peptic ulcer disease is proton pump inhibitors. So in the proton pump inhibitors, first we have okay. So first we will see how the gastric mucosa is. So this is a cell in the which is gastric cell. Okay, it has a H plus K plus ATPase which will K plus ATPase. It has H plus K plus ATPase which will send the H plus ions outside and it will bring K plus ions inside. Then it has following receptors. It has M1 receptor. Okay, then it has one histamine receptor, that is H2 receptor. Then it has one more CKK, that is cholecystokinin receptors. Okay, all these M1 receptors and H2 receptors and CCK receptors, all these will activate this H plus K plus ATPase. Whereas if you see the prostaglandin E2, this will inhibit the H plus K plus ATPase. Okay, now we will see the first drugs which can be used. Actually, if we use NSAIDs will inhibit the COX enzymes and thus this will decrease the prostaglandin E2 production, and because of this, see, prostaglandin E2 will inhibit the HCl production. So once this prostaglandin E2 is inhibited by the NSAIDs, so there will be increased HCl production leading to peptic ulcers are seen. Whereas if you see, in order to prevent this, we have to give NSAID. For NSAID induced peptic ulcer, we can give a drug which is called as misoprostol. This misoprostol is a prostaglandin analog. So as a result, it will decrease the, it will inhibit the it will inhibit the HCl production. Then, but this is not the drug of choice. What is the drug of choice for peptic ulcer? For NSAID induced ulcer, also the drug of choice for NSAID induced ulcer is also proton pump inhibitors is the drug of choice for NSAID induced ulcer. Then we have M1 blockers. So in the M1 blockers we have pyrenzepine and we have tilenzepine. These pyrenzepine and tilenzepine is actually not available in India. Then we have the H2 blockers are also available. These H2 blockers include cimetidine, ranitidine, and we have famotidine. Then we have loxatidine. Then we have nizatidine. Okay, cimetidine, ranitidine, famotidine, loxatidine, and nizatidine. So if you see famotidine, this famotidine is actually most potent. Okay, this H2 blocker will actually block the H2 receptor on the parietal cells and thus it will inhibit the gastric acid secretion. It suppresses all the phases of the acid secretion from the basal phase, cephalic phase, gastric phase. It suppresses all the phases of the gastric secretion. This H2 blocker also inhibits the nocturnal acid production also, and thus it decreases the acid secretion and thus it decreases the pepsin secretion for a shorter periods of time also. So these H2 blockers can be given orally or they are well absorbed or metabolized. They are metabolized in the liver and they are excreted in the milk. They cause side effects like headache, fatigue, myalgia and constipation. One of the H2 blocker we have is cimetidine. This cimetidine inhibits the CYP enzymes. This cimetidine will inhibit CYP enzymes and thus it increases the concentration of warfarin and theophylline. It increases the concentration of warfarin and theophylline. It is actually the least potent H2 blocker. And it can cross the blood-brain barriers and it thus changes the mental states. It also inhibits the binding of dihydrotestosterone to the androgen receptors. It inhibits the binding of dihydrotestosterone to the androgen receptor. and thus it causes impotence in males, and it inhibits the metabolism of estradiol also, and this cimetidine also increases the prolactin. Because it increases the prolactin, it will result in gynecomastia and amenorrhea. In male in females it causes galactoria. In females it causes galactoria and amenorrhea, whereas in males it causes gynecomastia. Then the next important drug which we have is nizatidine. Okay, this nizatidine actually has anti-acetylcholine esterase activity. So this nizatidine causes bradycardia, and it also causes decreased gastric emptying. It increases gastric emptying. It causes bradycardia and increases gastric emptying. So nizatidine is an anti-acetylcholine esterase activity, and it is used in bradycardia, and it increases gastric emptying. So this nizatidine has negligible first pass metabolism. It has negligible first pass metabolism. Then the next important drug is we have proton pump inhibitors. Proton pump inhibitors, the prodrug is proton pump inhibitors. So these proton pump inhibitors in the alkaline pH. In the alkaline pH, these proton pump inhibitors are given in prodrug. Okay, so once they reach the intestine, because of the alkaline pH, the coating which is present around the drug will dissolve, and the drug is released, and this is absorbed by the intestine, and by passive diffusion it is absorbed in the intestine. Okay, now by passive diffusion, the drug from the intestine, it undergoes passive diffusion, and it reaches the parietal cells, and it will the parietal cells. In the parietal cells, if there is acidic nature, then this becomes ionized, okay, and concentrated, and this drug will inhibit the sulfonamide cation, and thus it binds to SH group of proton pump, and thus it will bind to SH group of proton pump, and thus it will inhibit the acid secretion. Now, if you bind to the SH group of proton pump, it will inhibit the proton pump irreversibly. So the proton pump is now irreversibly inhibited. Now this will inhibit the proton pump. Okay, this proton pump is inhibited irreversibly. So now because the proton pump is inhibited irreversibly, it takes almost 24 hours for the proton pump to regenerate. So we give once a day dosing is given in this condition. These are called as hit and run drugs. Okay, then if you see the drugs, we have omeprazole. Then we have esomeprazole, we have omeprazole, esomeprazole, then we have pantoprazole, then we have rabiprazole, okay, then we have lansoprazole, then we have dexlansoprazole, okay, omeprazole, esomeprazole, pantoprazole, rabiprazole, lansoprazole, dexlansoprazole. So all these are proton pump inhibitors. Now we have esomeprazole. Esomeprazole has better activity than omeprazole. Esomeprazole has better activity than omeprazole. Now this esomeprazole and pantoprazole are given either oral or they can be given either IV. Then we have rabiprazole is most potent. This rabiprazole is most potent and it is faster acting. This rabiprazole is actually most potent and faster acting. So these are the important drugs which you see in proton pump inhibitors. What is the pharmacokinetics? They are oral and they are acid labile. Because they are acid labile, they are mainly given as enteric coated, which will be dissolved in the alkaline medium. The enteric coating is acid resistant. It is mainly given 30 minutes before the food, because for them to act, they need the acidic medium. So as a result, it takes minimum 30 minutes. It should be given at least 30 minutes before the food. Then, if given on empty stomach, there will be less parietal cells also, so they can be easily inhibited. Then, half-life of this drug is 2 hours. It is highly plasma protein bound. These proton pump inhibitors will mainly inhibit, or they are metabolized by CYP2C19. They are metabolized by CYP2C19. The other drugs which are metabolized by CYP2C19 are CYP2C19 is used in the metabolism of omeprazole, is metabolized by this, and also clopidogrel. Omeprazole and clopidogrel is metabolized by this. Okay. Now this omeprazole will inhibit the enzyme CYP2C19. So as a result, there will be increased clopidogrel. So this omeprazole is inhibits CYP2C19. But actually, normally, if you see CYP2C19 will normally activate clopidogrel. But Because the omeprazole is inhibiting this CYP2C19, this activation of the CYP2C19 by clopidogrel is not there, and as a result, the proton pumps do not act properly. So as a result, we should not combine omeprazole with clopidogrel. And if you see the side effects, they will decrease the absorption of calcium and vitamin B12. And because they decrease the absorption of vitamin B12, they cause megaloblastic anemia. If they decrease the absorption of calcium, they cause osteoporosis. And they also cause fractures of the bones also. These will result in pseudomembranous enterocolitis is seen, and you will also see presence of gastroenteritis, and these will result in pneumonia, and rarely they cause arthralgia also. Then these proton pump inhibitors will decrease the acid secretion. They will decrease the acid secretion and activate the gastrin. Okay, and thus they will result in ECL cell hyperplasia will be seen in them, and this is used in carcinoid tumor. Okay, then we have the drug latinoprostol. Latinoprostol is the drug which is actually safer in pregnancy. This latinoprostol is safer in pregnancy. Okay, then if you see the interactions, proton pump inhibitors will inhibit the metabolism of phenytoin. They will inhibit the metabolism of phenytoin. They will inhibit the metabolism of warfarin, and they will also inhibit the metabolism of diazepam. Metabolism is inhibited by the proton pump inhibitors. Then we have prostaglandin analogs. In the prostaglandin analogs, we have prostaglandin E1. And then we have prostaglandin E2, and we have prostaglandin I2. So all these prostaglandin E1, E2 and I2, all these will inhibit the H plus K plus ATPase. These will inhibit H plus K plus ATPase, and thus these will decrease the acid production. Okay, and all these will also increase the mucus production, and also they will also increase the HCO3 minus secretions. They will increase the mucus production and also HCO3 minus secretion. They will also increase the mucosal blood flow also. They will increase the mucosal blood flow also. So all these are actually cytoprotective effects. So in the prostaglandin E1, E2, I2 will inhibit the H plus K plus ATPase and increase the mucus production and mucosal blood flow. Now the side effects of these are, these causes diarrhea has the side effect, and also they cause abdominal pains with nausea, vomiting and flatulence is seen. These prostaglandin analogs are contraindicated in pregnancy. Why? Because these prostaglandin analogs will cause uterine contraction. Because they cause uterine contraction, these are contraindicated in pregnancy. The use is specific for NSAID-induced peptic ulcer. Then, if you see the drugs, what are the drugs? We have PGE1 analog, which is misoprostol. Misoprostol is PGE1 analog. I for 1. Then we have PGE2 analog. PGE2 analog is N-prostol. N-prostil, and also we have rioprostil. PGE2 analog is N-prostil and rioprostil. Rioprostil. N-prostil and rioprostil is P2ET analog. N-prostil and rioprostil is PGE2 analogs. Then we have antacids. So these antacids are mainly aluminium hydroxide we have, and magnesium hydroxide we have. These aluminium hydroxide and magnesium hydroxide, both these are actually contraindicated in tetracyclines, as these will decrease the absorption of tetracyclines. These will decrease the absorption with tetracyclines. So as a result, they are contraindicated in tetracyclines. So if you see the what is ideal antacid, the ideal antacid is any antacid which is soluble, which is insoluble, and which is capable of producing, which is insoluble and it is capable of neutralizing the acid is ideal antacid. It should not liberate carbon dioxide. It should not be absorbable. It should be non-absorbable. Okay, it should not disturb the acid-base balance in the body. It should not disturb the acid-base balance in the body. So ideal antacids are insoluble and capable. It should not liberate carbon dioxide. It should be non-absorbable, and it should not disturb the acid-base balance in the body. So if you see the drug interactions, these antacids will form insoluble complexes, especially with tetracyclines. This will form complexes are formed with tetracyclines, and it also forms complexes with fluoroquinones and ketoconazole. Then what are the antacids? Antacids, we have magnesium sulfate. First these antacids. These antacids can be divided into two types. One, we have systemic antacids. Second, we have non-systemic antacids. So in the systemic antacids, these include NaHCO3. Systemic antacids include NaHCO3, and these include sodium citrate also. These include NaHCO3 and sodium citrate. But these two are not used now. They are highly water soluble and releases carbon dioxide. These are highly water soluble and thus they release carbon dioxide, and also they cause abdominal distension also, and they cause belching. They cause metabolic acidosis, and they also cause rebound acidity. And these systemic antacids also increase the sodium load, and thus they increase the fluid retention also. They increase the sodium load, and thus they increase the fluid retention in hypertension, congestive heart failure, and renal insufficiency. Contraindications of systemic antacids are hypertension, congestive heart failure, and renal insufficiency is the contraindications of systemic antacids. Then we have non-systemic antacids. Then if you see in non-systemic antacids, so non-systemic antacids are of two types. First we have buffer type, and then we have non-buffer type. So if you see buffer type of non-systemic antacids, these include aluminium hydroxide. This aluminium hydroxide will combine with HCl in the stomach and forms aluminium chloride. And it forms aluminium chloride. And this will combine with bicarbonate and it forms aluminium carbonate. And also it forms aluminium phosphate and it forms sodium chloride. This aluminium phosphate is responsible for constipation, and this aluminium and sodium chloride is responsible. It will compensate the loss of chloride. And the sodium chloride will compensate the loss of chloride. Okay. Then we can also use magnesium trisilicate also. If you use magnesium trisilicate in the buffer type, you can use magnesium trisilicate also. This will combine with HCl and it forms magnesium silicate, magnesium chloride plus SiO2. It forms magnesium chloride and silica. These both will combine with bicarbonate and they form magnesium carbonate and also NaCl. They will combine with bicarbonate and they form magnesium carbonate and NaCl. This magnesium chloride and magnesium carbonate is the one which is responsible for diarrhea. Whereas these are the, in buffer type, this will result in aluminium phosphate will result in constipation, whereas magnesium trisilicate, it results in diarrhea. So if you combine this magnesium hydroxide and magnesium trisilicate, then the aluminium hydroxide, if you combine aluminium hydroxide and magnesium trisilicate, then the side effects will be nullified. Okay, this is about the buffer type, these two. Now we will see non-buffer type. Now in the non-systemic antacids, we have non-buffer type. In non-buffer type, these include, you can use calcium carbonate. This calcium carbonate will combine with HCl and it forms calcium chloride. This calcium chloride will now combine with HCO3 bicarbonate and it forms calcium carbonate and it forms calcium stearate. It forms calcium carbonate and it forms calcium stearate. Calcium carbonate causes carbon dioxide belching. It will result in carbon dioxide belching, whereas calcium stearate, it causes constipation. Okay, this calcium carbonate, if you give along with it with milk, then it results in hypercalcemia and it also causes renal insufficiency and causes metabolic acidosis. Thus, it is called as milk alkali syndrome. And magnesium hydroxide will cause diarrhea. Then the next important, if you see, the ulcer protective agents. We have ulcer protective agents also. These ulcer protective agents are complexes of aluminium hydroxide and also sulfated sucrose. Together we call it as ulcer protectives. So these sucralfate, first we have sucralfate. What does this sucralfate do? This sucralfate in the acidic medium. This sucralfate in the acidic pH, it undergoes polymerization and it forms a sticky gel with others to the base of the ulcer. And it forms a barrier against the acid and peptine. Okay, this sucralfate also increases the mucin production and bicarbonate secretion and prostaglandin secretion. So the main side effect of this sucralfate is it causes constipation. Okay, it causes constipation. It also causes nausea and aluminium toxicity is also seen due to sucralfate. Then if you see interactions, it should never be given with proton pump inhibitors, and it also decreases the absorption of digoxin and also tetracyclines, and it also decreases the absorption of ketoconazole and fluoroquines. Then the next important drugs are, we have bismuth compounds. Okay, in the bismuth compounds, we have two types of bismuth compounds. One, we have colloidal bismuth subsalicylate is present. Colloidal bismuth subsalicylate. We have colloidal bismuth subsalicylate is present. Second, you have bismuth subcitrate. You have colloidal bismuth subsalicylate and you have bismuth subcitrate. that is bismuth subcitrate potassium is there. So both these you do not need to polymerization, you do not need polymerize, these both do not need polymerization in acidic pH, so they can be given along with proton pump inhibitors, whereas the sucralfate needs polymerization in acidic pH, so you should not give the sucralfate with proton pump inhibitors, but here you can give it with proton pump inhibitors. So the side effects of these bismuth compounds are they cause blackening of the stool. They cause number one, stool blackening will be caused by them. They also cause tongue blackening and they cause osteodystrophy. They cause stool blackening, tongue blackening, osteodystrophy will be seen, and they also cause encephalopathy. Okay, they cause stool blackening, tongue blackening, osteodystrophy, and encephalopathy is seen in bismuth compounds. Then we have something called as triple therapy. So what do you see in triple therapy? In triple therapy, we have proton pump inhibitors will combine with two antimicrobials. Like it will combine with number one, clarithromycin, and then it will also combine with amoxicillin. Okay, it combines with clarithromycin and amoxicillin and also metronidazole. So the proton pump inhibitors is combined with any of these two antimicrobials, and they are given for 14 days. So that is triple therapy. In quadruple therapy, you will along with this triple therapy, if you add colloidal bismuth subsalicylate, then you should give quadruple therapy. Along with this triple therapy, if you add colloidal bismuth subsalicylate, then it will result in quadruple therapy. Then we have something called as prokinetic agents. So what do you see in prokinetic agents? What are prokinetic agents? These are central dopamine receptor inhibitors. Normally, dopamine receptor will inhibit the acetylcholine at the smooth muscles. Normally, dopamine receptors will inhibit acetylcholine in the smooth muscles. Okay. Now, if you give dopamine blockers, so as a result, there will be increased acetylcholine. When there is increased acetylcholine, obviously there will be increased motility. So obviously they can be used as prokinetic drugs. Okay, so they can also result in side effects. What are these drugs? Which are dopamine agonists. These are actually central D2 receptor blockers. We have drugs called as central D2 receptor inhibitors. These central D2 receptor inhibitors include, we have metoclopramide and we also have domperidone. These include metoclopramide and domperidone. Both these metoclopramide and domperidone will activate 5-HT4 and thus they will increase the motility. They will activate 5-HT4 and thus they will increase the motility. Then if you see, metoclopramide will increase 5-HT3 receptor. These D2 receptors will also inhibit the CTZ center. So as a result, they can be used in vomiting also, because they will inhibit the C2 CTZ, that is chemoreceptor trigger zone. Okay. Then if you see the side effects, in the side effects, one, we have metoclopramide. Metoclopramide has mainly extrapyramidal side effects. Metoclopramide will have extrapyramidal side effects. Mainly the side effects of extrapyramidal side effects, like there will be dystonia, there will be akathisia, and there will be Parkinson's disease. Metoclopramide will have extrapyramidal side effects like dystonia, akathisia, and Parkinson's disease. It will also increase the prolactin also. Okay, once it increases the prolactin, it will result in gynecomastia. And it will also result in galactorrhea. Then, if you see the uses are, it can be used in nausea, vomiting, and it can be used in constipation, diabetic mellitus, gastroparesis, you can use it, and you can also use it in post-operative gastroparesis also. You can use this metoclopramide and domperidone. Then, what about the cholinomimetics? We have some of the cholinomimetics which can be used as the prokinetic agents. Especially these include neostigmine. Neostigmine is actually an acetylcholine esterase inhibitor. So it inhibits the acetylcholine. It inhibits acetylcholine esterase and thus it increases the acetylcholine. and thus it is used in colonic pseudo-obstruction in hospitalized patient. So this is used in colonic pseudo-obstruction in hospitalized patients, which is called as Auger-Lewis syndrome. We use this neostigmine. Then we have erythromycin. What does this erythromycin do? This will activate the motilin receptors, and thus it increases the gastroparesis. So it increases the motility. So where is it used? It is used in diabetes gastroparesis. We use this erythromycin. Then the next important, we have prucalopride. Prucalopride is present. This prucalopride is actually 5-HT4 agonist. So this prucalopride is a 5-HT4 agonist, and this is used in constipation dominant inflammatory bowel disease, bowel syndrome. It is also used in diabetic gastroparesis. Also it is used. Then we have one more group of drugs which are called as 5-HT4 agonists. These 5-HT4 agonists are, we have cisapride, we also have mozapride. This cisapride and mozapride are actually withdrawn. These cisapride and mozapride are actually withdrawn due to the cardiac side effect. Cisapride and mozapride are withdrawn due to cardiac side effect. Then we have dexloxyglumide. In dexloxyglumide, this dexloxyglumide is CCK-A antagonist. It is actually a CCK-A antagonist which will increase the motility. This is CCK-A antagonist which increases the motility. The CCK-A will inhibit the motility normally. So if you give CCK-A antagonist like dexloxyglumide, then this will increase the motility. Then we have motilin agonists are also present. What are these motilin agonists? These include metamcinal, and we have camincinal. We have metamcinal and camicinal. Metamcinal and camicinal, these are under the trial. Then we have rasicodotril. Then we have rasicodotril. These are actually enkephalin opioids. Rasicodotril, which are enkephalin opioids, these will get converted. These are actually metabolized by the enzyme enkephalinase. Enkephalinase will metabolize this, and this enkephalinase will inhibit the rasicodotril will inhibit this enkephalinase. Okay, so this enkephalinase normally decreases motility, and thus it causes constipation. Normally it decreases motility and it causes constipation. Now this enkephalin opioid is metabolized. Then we have enkephalinase inhibitors. Enkephalinase inhibitors will cause constipation. They will increase constipation, and they are anti-motility drugs. They increase constipation and they are actually anti-motility drugs. These enkephalinase are actually anti-secretory also. Because they are anti-secretory, they can be used in secretory diarrhea, and also they can be used in diarrhea which is dominant in irritable bowel syndrome. Then the next drug we have is tegoserod. This tegoserod is used in, it is actually withdrawn in India due to the myocardial infarction and stroke. Then the next GI drugs are, we have laxatives. In the laxatives, first magnesium hydroxide. Magnesium hydroxide will cause diarrhea, has a side effect, so it can be used for simple constipation. You can use this magnesium hydroxide. So these magnesium hydroxide are also used for bowel preparation for endoscopy. They are used for bowel preparation for endoscopy. You can use this magnesium hydroxide. Then you have the next group of drugs we have is bulk forming laxatives. In the bulk forming laxatives we have. So in the bulk forming laxatives, these include the drugs like lactulose, and then we have methyl cellulose. These include lactulose, methyl cellulose we have, and bran and psyllium. These include lactulose, methyl cellulose, bran and psyllium are actually the bulk forming laxatives. Then we have stimulants. In the stimulants, we have microinflammation in the bowel wall will occur because of the microinflammation in the bowel wall. These include bisacodyl. These include bisacodyl, senna, and cascara. These are actually the stimulants. Then we also have stool softeners. So stool softeners are, these will decrease the surface tension and softening of stools will occur. They include Decusate. Then we have liquid paraffin. These include Decusate. These will have liquid paraffin, and they are also mineral oil. Decusate, liquid paraffin and mineral oil are stool softeners. Then we have chloride channel. Activators. So in chloride channel activators, the use of this chloride channel activators is constipation, dominant inflammatory bowel disease. So here we have lubiprostone number 1, lubiprostone, then we have linaclotide, and we also have plenacanatide, plecanatide, linaclotide and plecanatide. This linaclotide and plecanatide, this will actually activate the guanyl cyclase, and thus they will increase the chloride secretions. Okay, even this lubiprostone can also increase the chloride secretions, and thus it increases the fluid content in the gut. Okay, then we have crofelemer. This crofelemer is a chloride channel inhibitor. This is a chloride channel inhibitor which will decrease the fluid content. It is a chloride channel inhibitor which will decrease the fluid content. The use of this crofelemer is non-infective. It is used in non-infective diarrhea. It is mainly used in non-infective diarrhea in HIV patients on ARTs. It is used in non-infective diarrhea in HIV patients on acute retroviral therapy, on antiretroviral therapy. Then the next important drugs we have is vomiting. Treatment of vomiting, if you see, we give acetylcholine blockers can be given. These acetylcholine blockers include, we have hyoscine and we have scopolamine. Acetylcholine blockers are hyoscine and scopolamine. So this hyoscine and scopolamine is used as drug of choice for motion sickness, and also they are used for primary mountain sickness. They are used as drug of choice for motion sickness and primary mountain sickness. Then we have the next group of drugs, which is H1 blockers. H1 blockers are doxylamine is actually a H1 blocker. This doxylamine is used as safest in pregnancy, and this doxylamine is used as drug of choice in morning sickness. We use this doxylamine. Then we have 5-HT3 blocker. We have 5-HT3 blocker include ondansetron, and we have granisetron, and then we have dolasetron. We have ondansetron, granisetron, and dolasetron are 5-HT3 blocker. Ondansetron are shorter half-life. Ondansetron includes shorter half-life. Granisetron and dolasetron will actually prolong the QT interval. Dolasetron will prolong the QT interval. Then we have palinosetron. This palinosetron is actually the most potent 5-HT3 blocker. This palinosetron is most potent 5-HT3 blocker, and it has longest half-life. Then we have D2 blocker. The D2 blocker include, we have domperidone can be used. This domperidone is actually the drug of choice in levodopa induced vomiting. It is drug of choice in levodopa induced vomiting. Then we have metoclopramide. Then the next drug we have is metoclopramide. Then we have NK1 blocker, or also called as substance P blocker. NK1 blocker, also called as substance P blocker. So this NK1 blocker or substance P blocker, this is released on cancer lysis. It includes eripitant, and we have rolapitant, eripitant and rolapitant, and we also have netopitant. Eripitant, rolapitant, and netopitant. So these eripitant, rolapitant, and netopitant are used in cisplatin-induced vomiting. Okay, this cisplatin-induced vomiting is of two types. So this cisplatin causes vomiting, and the cisplatin which causes vomiting has two main effects. One, we have vomiting within 24 hours. We have cisplatin-induced vomiting, and vomiting after 2 days. We have cisplatin-induced vomiting. 5-HT3 blocker is cisplatin-induced vomiting within 24 hours, and after 2 days we have NK1 blockers are present. So we have NK1 receptor blockers are, we have eripitant, aprepitant, and lorapitant, and also netopitant. Then the next important is, we have inflammatory bowel disease. In the inflammatory bowel disease, we have ulcerative colitis and also Crohn's disease. Ulcerative colitis and Crohn's disease, the drug of choice for inflammatory bowel disease is sulfasalazine is the drug of choice for inflammatory bowel disease, which is 5-amino-salicylic acid. Sulfasalazine, we have 5-amino-salicylic acid plus sulfapyridine. Sulfasalazine is 5-amino-salicylic acid and sulfapyridine. This 5-amino-salicylic acid is normally completely absorbed from the upper GI tract. So sulfapyridine will prevent its absorption. So normally 5-amino-salicylic acid is absorbed from upper GIT itself. So this sulfapyridine will prevent its absorption. And sulfapyridine is the one which is responsible for all the side effects like nausea, vomiting, bone marrow suppression, and also pancreatitis. Then if you see the mechanism of action, this sulfasalazine gets converted with the help of colonic bacteria. This sulfasalazine divides itself into 5-amino-salicylic acid and sulfapyridine. Sulfapyridine has no action, but this 5-amino-salicylic acid will inhibit both COX enzymes and also it will inhibit LOX enzymes also. It will inhibit COX enzymes and LOX enzymes, and thus it will decrease the prostaglandin and leukotriene production. It will inhibit COX enzymes and LOX enzymes, and it will decrease the prostaglandin and leukotriene production, and thus has anti-inflammatory effect. Then we have mesalazine. So the next drug we have is mesalazine. See, because it is degraded in the upper GIT itself, this mesalazine is actually a coated formulation of 5-amino-salicylic acid. Then we have all-salazine. In all-salazine, we have two molecules of 5-amino-salicylic acid and one more 5-amino-salicylic acid. Both these are linked by azo bond. That is all-salazine. Then we have valsalazine. Okay, valsalazide. In valsalazide, 5-amino-salicylic acid is actually linked to 4-amino-benzoyl beta-alanine. It is linked to 4-amino-benzoyl beta-alanine. 5-amino-salicylic acid is linked to 4-amino-benzoyl beta-alanine. Then what is the drug of choice? Drug of choice is first for inflammatory bowel disease. First and foremost, the drug of choice is sulfasalazine. And after giving sulfasalazine also, if there is no response, then you should give steroids. And steroids you give prednisolone is the steroid which can be given. If the patient is resistant to prednisolone, then you can give the drug cyclosporine can be given in these patients. Then in long-term treatment, you will also give sulfasalazine can be given to the patient, and also you can give mesalamine can be given to the patient. In long term, you can give sulfasalazine and mesalamine can be given to the patient. Next. The next important is Crohn's disease. So in Crohn's disease, if it has acute attack, in acute attack of Crohn's disease, you give steroids are given, and if there is severe or fistula formation, then you should give tumor necrosis factor alpha inhibitor should be given, and infliximab should be given in the patients. Tumor necrosis factor alpha and infliximab should be given in the patients. And in long-term treatment, the drug of choice for Crohn's disease in long-term treatment is tumor necrosis factor alpha inhibitors can be given, like infliximab can be given. And if there is no response, then you should give vedolizumab. And if there is no response in vedolizumab, then you should give ustekinumab. Okay. So in transforming tumor necrosis, in Crohn's disease, if there is long-term treatment, drug of choice is tumor necrosis factor alpha. Drug of choice for long-term treatment of Crohn's disease is tumor necrosis factor alpha, which is infliximab. If there is no response from infliximab, then we give vedolizumab. If there is no response from vedolizumab, then you can use ustekinumab can be used. Then if you see other drugs which are used here include, other drugs are, you have azathioprine and 6-mercaptopurine can be given. These are actually ulcerative colitis and Crohn's disease. Then we have methotrexate can be given. This methotrexate will induce remission. It will induce and maintain remission in Crohn's disease. Then we have tumor necrosis factor. Tumor necrosis factor alpha inhibitors can be given, like infliximab. We have certolizumab. Okay. Then we have etanercept. And then we have adalimumab. And we have golimumab can be given. So all these are given in moderate to severe inflammatory bowel disease.
Thank you, and thank you for watching.